Welcome. Welcome to all of you from Newcastle, and welcome to Newcastle. I'm very grateful to you all for taking the time to come to this first aHUS Patient Family Conference, and I realise there are people here from all over the UK, but there are people here from Spain as well, so people have travelled a long way to be here today, so you're extremely welcome. We've been thinking for some time of holding an event like this, and now is a particularly opportune time because, as you will hear today, there have been remarkable advances in our understanding of this disease, and I hope that what you're going to take away from this is that there's been a really dramatic change in the prospect of the future for patients with atypical HUS. So I want to, before I introduce our first speaker, acknowledge the support of Alexion Pharmaceuticals, who have given us an unconditional grant for this day, so they can't control what I say about eculizumab, but I'm very grateful to Alexion for supporting the day. We've got a whole series of speakers who are from the UK, all of whom are experts in various aspects of this disease. And the first one, who I'm going to introduce right now, is Sally Johnson. So Sally is a pediatric nephrologist who works now in Newcastle. She previously trained in Birmingham with Mark Taylor, and she's got a vast experience in the treatment of not only atypical HUS, but all forms of HUS. So Sally's going to start off by telling us what is atypical HUS. So Sally, over to you.
Hi everybody, it's a real pleasure to be here to speak today, and I think everyone in this room is an expert in some way in this disease, and I'm going to just help us to focus by thinking a little bit about this disease. I don't think I need to explain that the abbreviation here, aHUS, obviously stands for Atypical HUS. So I'm going to talk a bit about what we as doctors mean by atypical HUS. Going to have a little look about what's actually going on inside the body, what's actually causing this illness. Just run through a few of the symptoms, how people might know if they've got atypical HUS. And then I'm going to talk a bit about what causes the disease. And in that, I'm going to refer to some talks that are coming later on in the day, but I'm just going to give you a bit of a taster. And I'm going to look at where we are now with how we've been treating this disease so far before we move on later in the day. And then towards the end of the talk, I may be able to invite a friend to talk a little bit about what the disease means to them. So, going to the dictionary, what do we mean by atypical HUS? So, atypical is obviously something that doesn't conform to the usual type. It's irregular or unusual. Hemolytic means breaking down red blood cells. Uremic refers to high levels of urea in the blood. So, urea is a waste product that's usually cleared by the kidneys. So, if it's high, it indicates that the kidneys are failing. And a syndrome is basically a word we use to describe a set of signs and symptoms that tend to go together, and when they're there together, they indicate a particular disease. So what's actually going on inside the body? So to have a look, we need to go in the kidney, and if you look in this bit of the kidney here and expand that up, you find lots of these little things called nephrons. So the nephrons are the little filtering units of the kidney, and we've got about 1 million in each kidney. And the nephron is made up of two bits, really. A blood vessel that comes in, makes a ball of blood vessels, and that's where the blood comes in. That's called the glomerulus. And that basically is under high pressure and squeezes the blood and makes the urine, which collects in this tube here. And it's the glomerulus which seems to be particularly affected in atypical HUS. If you were to do a kidney biopsy and take a slice right through that glomerulus and then to put it on a slide, so you've just got a tiny thin slice, you'd see this. So this is the capsule around the outside, and this is the ball of blood vessels, most of which have been cut end on. So you can see these rings, these pink rings with a white circle in the middle, and that's a blood vessel cut end on. So you can see a nice hole in the middle of the blood vessel where the blood flows through. If you were to do a similar biopsy in a patient with atypical HUS, you'd get this kind of picture. So you have the capsule around the outside, but unfortunately the kidney is filled, this glomerulus is filled with this pink material inside the blood vessels, and you can no longer see these nice open blood vessels. And that pink stuff is actually small blood clots. And so those blood clots are blocking up the blood vessels in the kidney, and the blood vessels lining those, the blood cells lining those blood vessels are very swollen, and so you have a blockage. So if you take one of those blood vessels and you cut it lengthways, so you're looking across as blood flows from here to here. So you have the nice cells lining the blood vessel, and the cells of interest here are red blood cells, which are the things that carry your oxygen around your body and make your blood nice and red. And the platelets are little cells, or parts of cells in the blood that help to clot the blood if you have a cut and you're bleeding. And normally those flow along nicely and go to wherever they've got to go to. But if you look at a blood vessel that's affected by atypical HUS, you see that those cells lining the blood vessel are very swollen and thickened, and those red blood cells and platelets become trapped in tiny blood clots. So as the blood flows through, blood cells become trapped, and the cells that come out the other end are damaged, so they're broken into fragments. And this is why you become anemic with atypical HUS, because the blood cells are actually breaking down, and these are then removed because they're damaged. Also, you can see that the platelets, the things that normally clot the blood, have been used up within these small blood clots. So you also have a low platelet count, which lots of you will know is a sign of HUS occurring. So that's what's happening inside the blood vessels inside the kidney. But I think it's important to know that it's not just the kidney. So the kidney is definitely the most frequent organ attacked by HUS. But it can happen in any area where there are small blood vessels. So we see people with atypical HUS with problems involving the brain, the back of the eye, the pancreas, which is a gland that helps you digest your food, and also in the heart and other organs. So how might you know that you're being affected by atypical HUS? Well, like this person here, you might be a bit pale and tired. So that's because of anemia. So you haven't got as much red blood cells, so you become pale. You haven't got as much oxygen carrying capacity, so you become tired. Some people get some bleeding, so maybe nosebleeds because of the lack of platelets in the blood. Some of the more non-specific signs of kidney failure might include passing less urine than usual, vomiting, starting to swell up, so swelling around the eyes, swelling around the ankles. And if things are quite advanced, breathing difficulty because of fluid on the lungs, because of fluid overload. We also know that atypical HUS causes really quite high blood pressure in many patients, and that in itself might cause symptoms like headaches, can even cause fits if very high, various funny turns. So those are the sorts of things that you might recognise that you've seen in some of your family members or in yourself. So then, on to what causes HUS. I've taken the atypical off the front here because I just want to talk a bit about HUS as a whole, because it's actually something that's been in the news quite a lot recently because of the E. coli outbreak in Germany, and I'll mention that because HUS is something we as kidney specialists see quite a lot of, but the vast majority of the HUS we see is not atypical HUS, it's typical HUS. But what I'll say is that anything that causes HUS seems to do it by making these blood vessels unhappy, particularly those in the kidney. So anything which really damages these blood cells, which are lining the blood vessels in the kidney, and can cause them to swell up and develop those clots in the kidney, can cause hemolytic uremic syndrome. And leading on to that same picture we've seen before. So I mentioned typical HUS there. Some people might know that as diarrhea positive or D positive HUS. And that's what we've been hearing a bit about in the news from Germany. So This type of HUS, which is more than 90% of the HUS we see in this country, is caused by a bacteria which produces a toxin. And it's that toxin, known as Shiga toxin, which is very damaging to those blood vessels that line the kidney. And the bug that usually we see in this country producing that is an E. coli, and the particular type is called 0157. The outbreak in Germany has been caused by an E. coli, and that's the type 0104, and that's been a particularly virulent strain. But it causes HUS by the same mechanisms. The toxin damages the blood cells lining the kidney and other organs and produces that syndrome that we see. Now, this type, apart from the German outbreak, which seems to be more prevalent in adults, particularly women, this form of HUS tends to happen mostly in children. Usually a single episode. You have it once, you pick up the bug, you get the illness. You can be quite damaged by the illness. You could end up with kidney failure, but on the whole, there's a good outcome, and by far the majority of people who have this form of HUS have a good outcome. They may have some long-term damage to their kidneys in later life, but on the whole, a good outcome. Which then brings us on to the other form of HUS, which we're talking about today, atypical HUS. This has been called many, many things over the years. Diarrhea negative, D negative, familial HUS, inherited HUS, relapsing, sporadic, lots and lots of different words to describe essentially that type of HUS that doesn't come with E. coli and the toxin produced there. And it was noted a long time ago that even before we knew about E. coli, we knew that some children had this diarrhea-associated HUS, where they had a bloody diarrhea, they got HUS, and they generally got better. But there were a number of patients who didn't have evidence of bloody diarrhea. They perhaps had HUS in other family members. They had episodes which came back, so it wasn't a single episode, and they developed a progressive kidney failure with each episode, or developed dramatic kidney failure with the first episode. And really importantly, the HUS came back in their transplanted kidneys. So that led many investigators to think that there must be a genetic underlying cause for this type of HUS as opposed to the more typical form. And this led on to some investigations around the world, but predominantly here at that time in Newcastle, where Tim and Judith Goodship led this study with Paul Warwicker, where I know that there are families in this room who were represented in this study, where they first described a problem with one of the genes included in the complement system. Now, that particular gene was called factor VIII, the factor H gene. And this was the first paper to describe abnormalities in the factor H gene. I'm not going to talk much more about genes or much more about complement, because you're going to have two talks about that later on. But I'm bringing this in because it's relevant to where we are today. So don't panic, you're going to hear lots more about complement and about genes. But this was the first study to show abnormalities in a particular gene in the complement system. And this paper really did open the floodgates for research into the complement system in atypical HUS. But really, the complement story from that time, 1998, kicked off. And over the next 3 or 4 years, there were groups around the world who started to publish, so people in this room who published papers on factor H mutations in families like yours represented here. And every single one of these studies looked at families in whom there was HUS, atypical HUS. And this led to these findings. And then after factor H came the MCP, or membrane cofactor protein story. So that's another protein involved in complement. So a few years later, problems in those genes were noted. Then another gene, factor I, again, so 2004. You can see the speed at which this was progressing. We started off in 98, and by now we've got to 2005, and we have all these genes being identified. And more followed. So this story of HUS and complement in HUS has been developing, until very, very recently, that there are, and people in this room will recognise perhaps their particular gene in this list. But just to say that this has just been happening very, very quickly over the last couple of years. And a particular point that, as well as gene problems, it's also known that some patients have atypical HUS because of they have an antibody, so that's part of their immune system is reacting to their own natural protein, factor H. They don't have a genetic problem, but they have a reaction to their own factor H protein, which really gives a disease that looks exactly the same as if you had a genetic problem. And there are groups around the world right now, from all these countries and more, who are solely dedicated to the study of atypical HUS and have brought us all those papers and are now advancing further. So this brings me to where we are now in 2011. The next slide is quite complicated, but I think it just summarises what we know so far. And I'll take you through it. So on the first column here, we've got a list of the different genes that we know to have mutations in HUS, and also at the bottom, anti-factor H antibodies. We've got a list of the frequency. If you take a population of people, say 100 people with atypical HUS, that's how many of them will have each of those particular problems. And if you add that up, it comes to around about 70%. So if you take 100 people with atypical HUS, we'll probably find a known problem in 70 of them, which means that in the remaining 30, there's still work to be done. And that's partly what those groups are still working on. But we strongly suspect that the majority of those will still have problems with the complement system. This looks at the age at which people present with these particular problems, and I will say that any problem could present at any age, but they tend to cluster at particular ages. Some of these onset in the first year or two of life, and some are more variable, and some are later in childhood, some in adulthood. And the final column is, for me, that's why everybody's in this room. The final column looks at the outcome, as we are now, of these particular forms of atypical HUS. And the abbreviation ESRD stands for end-stage renal disease. So that's kidney failure requiring dialysis and transplant. And you can see that for all of these different problems, apart from a couple, there are really high incidences of end-stage renal disease within a few years after presentation. And as I said, I think that's why we're all here, because this is what we are trying to change. So, and the other point that comes from these is that a number of these conditions will recur after a transplant because of the genetic abnormality underlying. And so that's what we are working to try to change, so that in 5 years' time when we stand here, that column says a completely different thing. So just very briefly, how do we treat atypical HUS? You'll know about this. On the whole, we do supportive treatment, so that means we basically support you through the illness. If your kidneys are failing, we give you dialysis to replace your kidney function. If the blood pressure is high, we treat it with medication. We do use blood transfusions because you can become quite anemic with atypical HUS. And we would just give you blood transfusions to top up if you were having an acute episode. Nutritional support is really important, especially in children. And then there are a couple of forms of active treatment. That means where you're actually kind of doing something apart from supporting you. And I've just put plasma therapy and transplantation. We're going to have much more information about transplants later on. But we do use plasma therapy, and as a number of you in this room will be experts in plasma therapy and what that actually means. But essentially, I've just sort of shown a diagram here. So here's our blood flowing through the blood vessel. And the pale straw-coloured stuff that the blood cells float in is called plasma. It's the watery part of the blood. And if we know that you're deficient in a particular complement protein in your blood, then we could just give you some plasma, like an infusion of plasma, to top you up. But for most people with atypical HUS, we know that that's not enough. And so we do something called plasma exchange, where we essentially take out that straw-coloured fluid through a circuit and replace it with normal plasma. And that has to go on over a number of hours so that all that plasma can be exchanged by fresh plasma. And we do that. And it has some success, but I think all of us who either treat atypical HUS or who've experienced the treatment know that plasma is not a magic cure. It does not necessarily stop episodes of HUS, and some people can be quite resistant. And so that just leads me to set the scene for the future. I've told you where we are now with the treatment historically, and now that we know much more about complement in atypical HUS, which we'll hear a bit more later about, the future really is to have medicines which target the complement system alone, and therefore you don't need to have lots of plasma therapy, and that would stop you losing your kidneys from this disease. So I'm just going to ask, I've told you what I think about atypical HUS, and I'm going to ask Margaret to come up and tell you what she thinks about atypical HUS. Margaret is from the West Country and has really been a part of what I've just told you about, in that her family were part of one of the studies looking at factor H mutations in HUS. Would you like to tell everybody here what you think about atypical HUS, what it means to you?
It's affected our family quite a lot. I'm sorry. Back in 1963, I had a cousin diagnosed in her 20s with kidney failure. And it was, don't know why it was kidney failure, but we didn't know much about it. And she died within a few weeks, having been given dialysis. It was in its early stages, so it wasn't particularly good. She was travelling from Torquay up to Bristol at the time to have dialysis. A few years later, her sister, having had a baby, normally became ill. We later discovered that she had problems feeding the baby, and she had been given a hormone therapy to help dry up the milk. And she developed kidney failure, and she died. The next time we saw it in our family was in the 70s, the mid-70s, when one of our sons presented. He was 5 months old. He'd been ill beforehand. He'd been ill when he was very small, when he was a few weeks old. And I'd gone to see the doctor and said, my baby's not like he ought to be. He's very pale. He's not drinking very well. He's not gaining weight. And I asked to see a paediatrician. That was in the July. And as things are, it was the September time we saw the paediatrician, and at that time they said he'd got a baby anemia, and they thought he was probably improving. They kept him on their books and saw his anemia, or his hemoglobin, was going up. They signed him off in late October. December the 1st, I rang my doctor. I said, Richard's not very well. He's quite poorly. He's very pale, and I'm noticing pink in his nappy. So he said, we'll get you into hospital. It later transpired that the consultant, when he'd signed us off, had said to the GP, I'm not sure that this is a normal baby anemia. We'll keep an eye on it. So we went into hospital with Richard. It was a week before they discovered that it was HUS. They tested for everything. They gave him blood. Now we can look back and say keep giving him blood didn't actually improve his condition because it caused more damage in the kidneys. But we lost Richard. And I'd said to them, is this an hereditary condition? Because I lost 2 cousins with kidney failure. no, HUS is not hereditary. Go home and have another baby. So we went home and we had another baby. 2 years later, I rang my doctor up because my baby was poorly and said it's the same again. No, Margaret, it won't be the same again because it's not hereditary, but I will send you in to check it out. We'd only been in the hospital a few hours when they said it was the same again. Back then in the 60s, they didn't know about the factor H. They didn't know anything about this. They could only treat what they saw was HUS, and we lost Michael as well. Now, years went on, and then I had a phone call from the doctor, would I be involved in this study that was being carried out from Newcastle. And we had Dr. Paul Warwicker come down and take bloods from a number of people in the area. And then, as we know now, that was all identified. Now, from losing little Michael in 1977, earlier part of 1977, there was nothing in the family again until 2005. I had a phone call one morning from my sister-in-law saying that my brother's grandchild in Switzerland, a little girl, was poorly. She told me the symptoms, and I said, oh no, not again. So, and Jana was ill and diagnosed. We sent out all the papers that we had that had been done in 1998 to Switzerland because they had diagnosed this child with HUS and couldn't quite understand why this child that hadn't presented with diarrhea had got HUS. They kept asking my niece if she'd had diarrhea, and she said, no, she's not had diarrhea. So obviously in Switzerland, once they got the papers and they knew the problems, they got on and treated Jana. Jana is now coming up to 6. She's having plasma. It's plasma infusion they have over in Switzerland, and she's having it once a month. Unfortunately, her younger brother, Jason, he developed the condition as well. He was 4 months old when he became ill first. He's had a couple of relapses and not been doing too well. But our grandson, little Jake, he developed the condition earlier this year. He was 18 months old, or 16 months old actually, when he developed the condition. Becky, we'd been away on holiday, and when we came back, Becky had said he's been having lots of dirty nappies, teething, as children do. He's a bit pale, but he's all right, Mum. And then the Sunday morning, she rang me up. She said, Jake's not very well, Mum. She said, come down and see him. So I did. Jake was very pale. Becky had said he was whinging a lot and sitting on her knee, which he was. I took a look at him and thought, I've seen that pale look before, when children look almost opaque, you know. So I said, I think we ought to take him in to hospital, to the walk-in centre. It was a Sunday morning, and we wouldn't have got our own GP because, I mean, he obviously knows the problem in the family. So we took Jake in. I think I was a bit impatient because I didn't think they took his blood very quick to identify it, but they did. And in the early hours of Monday morning, they said that he'd got the condition. And being a typical grandmother, I rushed right into hospital and said, don't give him too much blood because it damages the kidneys. And I knew about the plasma because we'd seen it with the 2 in Switzerland. And so we saw this very poorly boy for a few days. I mean, he went through, in those early hours of Monday morning, he was quite poorly. His heart was struggling. They gave him the blood. And then later in the day, they transferred him up to Bristol, where he's been on plasma exchange. Now, the first few weeks weren't particularly nice, as all of you who's seen the condition will know. And gradually, from having plasma every day, they reduced it, got it down to 3 times a week, and then let him go home, so he travels the 80 miles up to Bristol. Then went down to twice a week, and now he's on once a week. I think the thing that I see with the condition is that this little child of 18, well, he's nearly 20 months now, with these 2 little tubes in that can't do what a normal child would be able to do, because all children love playing with water and you can't get the sweat. So it's not a normal life. Although to see him, you would think he was a healthy toddler now, and developing well. And then recently, my brother and sister-in-law's little grandson over in Switzerland has had a relapse, and he's very poorly at the moment.
I mean, thank you so much, Margaret, for sharing with us your experiences. I know that's not been easy.
No.
I'd like to sort of to say from your story how your story shows how far we've come, in that when this first happened to you, no one really knew very much about it. And I think what's happened in the generation that have been poorly now is that the diagnosis has been made and they've had treatment. And you know how difficult that treatment is to have, because it's ongoing. But also your story says how important it is for the people like you and your family who've participated in the studies that have been led by Professor Goodship and others, in order to take us from that time where no one really knew what was causing it, and children were affected and had a very bad outcome, but we've come forward to a place where we now recognise it and can treat it in a certain way, but what we want is better treatment, so that you're not as your grandchildren currently are.
Yeah.
So thank you very much for sharing with us.
Thank you.